Hi, good evening everyone. Okay, Krish, I'm fine. Namaste. God bless you. Okay, so I welcome you all to Unacademy. So today we'll be having a very long class, probably of 1.5 hours. Okay, so we'll be discussing a lot of important things in this class. We'll be discussing miscellaneous important concepts, and we'll be discussing the flashcards. We'll be discussing a lot of things. So let us start with this, but before that, do make use of Unacademy and its resources. We have wonderful options. And remember, before the price hike, do join an academy if you are planning to. And we have a lot of new batches which have been already been launched. So let us start with this session. Okay. So the first concept that we are going to discuss today is the concept of knot. Is the concept of knot. Yeah. So what knot are you seeing in front of you? What knot are you seeing in front of you? What kind of knot is this? Yeah. Reef, granny, Aberdeens or Melzers. Yeah. Reef, grannies, Aberdeens or Melzers. Answer is, this is a two-throw knot. Yeah. So this is a what knot? This is a reef knot. This is a reef knot. How do you identify the knot on image? This is again a very important question. So when we talk about identification of knot, so knots may be 2-throw, 3-throw knots. So how to identify between a reef versus grannies? So how to identify a reef versus grannies? Yeah. How do you do this? The objective, the point number one is always select any one end. So select any one end. Okay, so try to understand. Select any one end and then look for symmetry. Look for symmetry. Always remember, if the knot is symmetrical, if the knot is found to be symmetrical, then that is a what knot? That's a reef knot. That's a reef knot. And if the knot is found to be asymmetrical, yeah. If the knot is found to be asymmetrical, then that is what? That is a granny's knot. So this is how we see a reef versus grannies. A reef versus grannies. This is how we see a reef and grannies. Now in this knot, if you see, let us select this end. If you see, the orange thread is below the blue or no? So orange is below the blue. If you see here. Here also, students, orange is below the blue thread. So above and below. Yeah, this is what. Similarly, here if you see, blue is above. So the blue is above the orange, and here also blue is above the orange. But see, if you stand here also, you will see orange is above. So what kind of knot are you seeing? This is a symmetrical two-throw knot. This is a symmetrical two-throw knot, and that is a granny's knot or a reef knot. It's a reef knot. Krish, why are you saying it's to be grannies? I'll show you one more image. So there you can identify whether it is a grannies or a reef. So just wait. Yeah, let me show you this. There is one more image. You can identify knot in that. So I'll cover all of them here only. Unfortunately, we don't have, but I'll show it from different side. Just a minute, huh? Just give me a minute. I'll show you the image. And there we can see. I'll show you a Granny's knot pick, and then we'll discuss what it is. Okay. Try to see this knot. Try to see this knot. And try to identify it. Just see. But here, if you see, select any one end. Suppose you have selected this end. Blue is above. And here, the blue is what? The blue is below. Here, if you see, the red is below. The red is below. And here, the red is what? The red is above. So, bachche, tell me, is it a symmetrical or a asymmetrical? Either dekh lo. The red is above and here the red is below. So, this is a symmetrical knot. An asymmetrical knot. This is what is a Granny's knot. This is a Granny's knot. Do you know that Granny's knot is an insecure knot? Granny's knot is an insecure knot. I will show you the concept. I'll show you one more concept. Try to understand. I've got a thread for you. Yes, and I will show you how to see this thing. So this is a thread. Now if I want to tie a knot, I will have to exchange the ends. Yeah. Always remember the orientation. What is the orientation? If you are taking a symmetrical, like if you see, I am putting this thread over this. So this is on top. So I'm taking from top to bottom. So this thread will always remain on top. Again from top to bottom. So I have maintained that symmetry. And can you see the type of knot that has been created? The type of knot that has been created. Yeah. This is a what? This is a symmetrical knot. This is a symmetrical knot. Yeah. Because of the chroma effect, it is getting a green color. That is why it is not hitting. So this is a symmetrical knot. Always remember the symmetrical knot gets locked. Symmetrical knot gets locked. It will not slip now. Yeah. It will not slip. Ab dekho. Next is. Just see. Now this time I will not follow the order. I'll just do a different color to this knot so that you can see. I'll do some black color on this thread so that you can see. Because of the chroma effect, I'm not able to show you the knot. Okay, I've done some coloring on this. So this time I will do the second orientation. I have taken this knot above this. Can you see? This thread is above this. And now I will keep this thread below. So this is an asymmetrically created knot. And now you will see this knot. This is a slip knot. Can you see this knot is slipping. This is what is a what knot? This is a slip knot. There's a difference between a Granny's and a reef. A reef was locking. This is slipping knot. Now what is the utility? But if this knot is not useful, then why do we actually acknowledge that? So whenever you are doing a surgery in the deeper parts, like in the pelvis or around the cholecystohepatic triangle, gallbladder, when you're doing open surgery, you are tying the knot from above. Yeah, you are tying the knot from above. Imagine you create a reef knot. What will happen if you create a reef knot? The calots is down there. Now what will happen? Can you see it has locked? It is not sliding and this knot will always become weak. Now imagine I have to go down. Just come here. Show me a finger. Yeah. So imagine I have to go down. This is my assistant's finger and this is the suppose cystic artery. I want to ligate the cystic artery and imagine I create a what type of knot? I create a reef knot. It will get locked. Ye jayegi nahi. So what I need to do? I need to create a knot which should first slide down. And just see what I will show you. Just see what I will show you. I have gone a knot. I will create a asymmetrical. I will create a asymmetrical knot and I will slide this, slide this. Can you see this is sliding now? It has slided and now I will tie one more knot. So this is the utility of Granny's knot. This is the utility of Granny's knot. Are you getting this? The utility of Granny's knot is that it will slide down. It will slide down and it will go to the desired point. Yeah. This is what. Let me show you the other types of knots also. Let me show you, because knots is again a very important. I hope Granny's and reef, is it clear? A basic difference is clear. Its utility is clear. No? So when we talk about the knots, knots are of two types. We have open surgical knots. We have open surgical knot and we have laparoscopic knot. Laparoscopic I will not show, because if you want to see them, go to my YouTube channel. N number of laparoscopic surgeries and everywhere I've used some knot or another. So open, we have two throw knots. Two throw knots. What are two throw knots? Two throw square knot. And this is also known as reef. This is reef. But see, what are reef? They are symmetrically crossed knots. And two throw asymmetrically crossed knot. Asymmetrical knot. And this is what is known as Granny's. Always remember, reef is equal to secure knot, whereas Granny is equal to insecure. Since it is insecure, why it is insecure? Because it slips. So this is a slip knot basically. Therefore requires extra hitch to secure it. Extra hitch to secure it. Are you getting this? Yeah. Are you getting this? Ab dekho. The next is the surgeon's knot. Yeah. The next is the surgeon's knot. Because a lot of people teach what is a reef, what is a Granny's. पर ये लगता है ना कि भाई when Granny's is useless, then what is the utility? But see, Granny's is a beautiful knot. If Granny's was not there, देखो, today in life, in order to survive, you have to be flexible. And if you are not flexible, you will not be able to survive. Granny's knot can be used everywhere, but reef cannot be used everywhere. The only thing that you need to ensure that whenever you create a Granny's or a slip, do ensure that you pass an extra hitch to secure it. Are you getting this? So surgeon's knot, it's a 3-throw square knot. It's a 3-throw, you can say crossed knot. So it's a symmetrical 3-throw knot. And then we have Aberdeen's. What is Aberdeen's knot? Can anyone tell me what is Aberdeen's knot? Anyone? This is loop out of loop knotting. This is loop out of loop knotting. So students, if you are doing a continuous suturing, imagine you are doing a continuous suture. Yeah, this is continuous. Now you don't have any end left. How to tie the knot? The last loop you will enlarge and you will take out the loop inside the loop. You will take a loop inside the loop. Yeah. So last loop you will enlarge and you will take a loop inside loop. So loop inside loop and then ultimately you will tie the knot. So loop out of loop knotting. I'll show you and then you will have a better understanding. I'll ask you an image based MCQ also. There's an image based question also on this. Can you see this knot? Loop out of loop knotting. Loop out of loop knotting. So answer here is what? Aberdeen's. Aberdeen's is the answer. Aberdeen's is the answer. This is loop out of loop. This is the last loop. And what you are doing? You are pulling the loop out. Can you see? So within this loop, you have created one more loop. And this way you are locking the loop. And then finally you will terminate it. So I'll show you again a video. So you'll have a better understanding. What is an Aberdeen's knot? What is an Aberdeen's knot? Try to see. I'm doing a gastrojejunostomy. Yeah. I'm doing a gastrojejunostomy and this is the anterior layer I have closed. Almost I have closed the anterior layer. So can you see I have closed the anterior layer. Now I will require, yeah, I have closed it. I will require to terminate this knot also. Yeah. So how will I terminate this knot? Just see. Can you see how do I do? This is the last loop. I was doing a continuous suturing. This is the last loop. Can you people see this loop? Now just see what I will do. Can you see? I am going to pull the knot, pull the loop out of loop. Can you see? This is a loop and I am going to pull out the loop. Yes, I have created a loop. Can you see a loop out of loop? And now again I will lock it. Can you see I have locked it? Again I will create a loop. Again I am going to pull a loop. Can you see? Again I am going to pull a loop. So loop out of loop again. Again I am going to lock it. Again I am going to pull a loop. Just see bachcho. Can you see? I am doing a loop out of loop. Loop out of loop. Bachche, that is why surgery is a practical subject. You cannot mug up. You have to remember it. You have to understand it. So loop out of loop, loop out of loop. Again lock it. फिर से. Yeah. So I have done a multiple loop out of loop locks. And finally what I have done, I will pull out the thread from this. Ultimately, so I started loop out of loop locking and then I have pulled the thread. Can you see it has been secured now? Just see. It has been secured. So what is this? This is Aberdeen termination. Do you know what is this knot technique better known as? What is this knot technique better known as? This knot technique is better known as Dundee jamming and Aberdeen termination. This is also known as Dundee jamming and Aberdeen termination. Aberdeen termination. Why this is known as Dundee jamming and Aberdeen termination? This knot technique was devised in Scotland. And in Scotland, if you see, Dundee is the northernmost tip. So we start with Dundee jamming. That loop out of loop part is a Dundee jamming. And Aberdeen termination. What is Aberdeen termination? Yes, you will take out the knot out of this. Are you getting this? Dundee jamming and Aberdeen termination. Clear? Next is when you talk about laparoscopic knots. Yeah. Clear to everyone? Yeah. When you're talking about laparoscopic knots, what are they? We have laparoscopic surgeon's knot. Surgeon's knot. Yeah. That's again a 3-throw knot. Yeah. That's again a 3-throw knot. Loop out of loop. Next is extracorporeal slip knot. Extracorporeal slip knot. What is the concept of extracorporeal slip knot? What is the concept of extracorporeal slip knot? Yeah. Extracorporeal. Can you tell me what is extracorporeal slip knot? Extracorporeal slip knot. What is this? What do you mean by this extracorporeal slip knot? We have two types of extracorporeal slip knots. What are they? The first one is a Rodder's knot. Yeah. And then second is a Melzer's knot. So we have a Rodder's knot and we have a Melzer's knot. So Rodder's or a Melzer's. What is Rodder's knot? What is Melzer's knot? Rodder's is 1-2-1 and Melzer's is 2-3-2. क्या होता है ये देखते हैं. What is the concept of this? Let us see. बच्चे, why it is known as extracorporeal slip knot? Extracorporeal. Why it is extracorporeal? These knots, the knot is created outside the body. So knot is created outside the body and secured, or you can say tightened inside. Is that clear or no? So knot is created outside the body and it is secured or tightened inside the body, and this is very important point about that. Yeah, we have two. Let us see. Let us talk about Rodder's. What do you mean by Rodder's? Rodder's is 1-2-1. What is this orientation of X, Y and Z? What is this X, Y and Z? X represents the number of loops, the number of hitches. First is the number of hitch. The Y represents the number of loops, and the Z represents the number of locks. So loop, locks and H. Let us see this also. Very easy to understand. Suppose this is the suture. Yeah, this is the suture you want to tie the knot. But see, the first thing that you will do is hitch. So this is hitch, and how many hitch? 1. The second thing that you want to do is a loop. So this is loop. How many loops? 2. And then the third thing that you want to do is lock. How many lock? This is 1. So the formula is 1 to 1. So the formula is 1 to 1. I'll show this to you. Try to understand. Similarly, what will be the Melzer's knot? Yeah, answer is 2, 3, 2. 2, 3, 2. Just try to understand this 2, 3, 2 formula. This is the 2 hitches, then 3 winds, and then again 2 locks. This is what I'll show it to you. Like if you have seen my latest video on you can say YouTube for laparoscopic appendicectomy, I've shown how we make this knot and do this. So I'll ask my assistant to to give us a finger, and then we will adjust the knot. So imagine I'm doing a laparoscopic surgery, and imagine this finger to be what? Appendix. Yeah, take it to be fallopian tube, take it to be cystic duct, kuch bhi. So what I will do with my instrument, I have taken the suture, and with another instrument I have pulled the suture out. Can you see I have pulled the suture out? Now just see how I will do this. Yeah. So the first thing I will do is I will take a hitch. This is hitch. Yeah, this is hitch. This is hitch. Now what I am doing? I am tying a loop. This is one loop. This is another loop. So I have taken what? 2 loops. The third is I am creating a lock. Yeah. So what is this? This is a knot. Now just see, I am sliding the knot. Pushing it with an instrument. Can you see I am tightening? But say you can use your any strength. Yeah. But this knot will not come out. Can you see? The knot will not come out. And this is so strengthy. Similarly, we can use this for different purposes. Like uterine stump. If you dissect the uterine beautifully, you can use this. Like I'll show you a Melzer's now. So with this finger, same way, this time I will take 1 hitch. I will take 1 more hitch. These are 2 hitches. Yeah. Next is I will take 1 wind. This is 1 wind. I will take another wind. This is second wind. I'll take 1 more wind. This is 3 winds. I'll take 1 lock, and I will take 1 more lock. So can you see the knot is fixed? Always remember not to pull the tail. If you will pull this tail, it will get locked. And now see, I'm going to slide this knot again. Can you see it has gone? Again, this is very strengthy knot. Yeah. This is what is the concept of extracorporeal what knot? Slip knot. If you want to see this, go to my YouTube channel, see the latest video of appendicectomy, and do like and subscribe it also. Let us move forward. Next is, let us talk something on this. Okay, identify the lesion. Yeah. What is this? A, B, C, D, E, F, G. Come on, tell me. Okay. So this is a classical case of what? Blood in the thoracic cavity. And what is this known as? What is happening? Students, there is some problem with the pencil. Just a minute. Just give me a minute. There's some problem with the pencil. This is a case of massive hemothorax. Just a minute. Just a minute. So what is actually helping you do the diagnosis? Yeah. What is helping you do the diagnosis? Answer is the blood in the thoracic cavity. Yeah. The blood in the thoracic cavity. So back. So blood in the thoracic cavity helps us come to a decision that this is a case of hemothorax. Hemothorax. Now let us read the options. Yeah. Pulmonary vein is the most common source. Pulmonary vein is the most common source. More than 1500 ml requires what? A surgical exploration. Let us see. Let us come back to the theory and then we'll discuss. So when we talk about the concept of hemothorax, what are the important things? Bache, the most common source is the traumatized intercostal vessels. So it is the ruptured intercostal vessels. It is the ruptured intercostal vessels which is the reason for this. Next is very important. Yeah, dull percussion, very good. Dull on percussion. The next is, what is the criteria to call something as a massive hemothorax? So when will you call it a massive hemothorax? The answer is, massive hemothorax is indicated when there is more than 1500 ml blood in case of adults into thorax. So in thorax, if you have more than 1500 ml blood, or in case of kids, or more than 25% blood volume. So more than 25% blood volume in kids into the thorax. So this is what is massive hemothorax. Now what is the management of hemothorax? What is the management of hemothorax? What is that? Be it hemothorax, be it pneumothorax. Yeah. Be it hemothorax, be it pneumothorax, what is the classical management? Yeah. You will have to evacuate it out. So tube thoracostomy, and this is to be done at what? At 5th intercostal space. So tube thoracostomy at 5th intercostal space via triangle of what? Triangle of safety. Now this triangle of safety is also very important. Why? What are the boundaries of triangle of safety? If you see, this is the pectoralis major. So this is the pectoralis major. Then we have mid-axillary line. Yeah. We have mid-axillary line. What else? And then imaginary line extending towards the nipple areola complex. Why nipple areola complex? Because this corresponds, nipple areola complex corresponds to the 5th intercostal space. And this triangle is what is known as your triangle of safety. Now, why this triangle of safety is important? Yeah, I'll tell about that. Staph, that is for pneumothorax in pediatric. If you have a pediatric hemothorax, then also you will go for 5th intercostal space only. Are you getting? Pneumothorax, I'll tell. Why? Because when you're doing for the pneumothorax, air being lighter can exit out. The blood will not come out. Staph, are you getting this? This is for hemothorax. So for hemothorax and pneumothorax, there's a bit difference. Yes. Okay. Are you getting this or no? Yeah. Are you getting this point or no? So in kids and in adults, both 5th intercostal space for hemothorax. Yeah. Next is, why triangle of safety? Because it is associated with what? Minimum collateral damage. I hope that's clear to everyone. Okay. Next is, what are the indications? What are the indications for thoracotomy? What are the indications for thoracotomy? What is tomy? Tomy means what? To open the thorax. Tomy means to open the thorax. So the first indication is massive. So massive hemothorax, which is more than 1500 ml blood. You will not. But investigation of choice, the first line investigation is always X-ray. And yes, CT chest is the investigation of choice in hemodynamically stable patients. Yeah. HRCT chest is the investigation of choice in hemodynamically stable. Otherwise, the chest X-ray AP view digital is sufficient to estimate everything. Is that clear? So bedside X-ray also can be done. Second is, so massive hemothorax. Now, suppose you don't have a suspicion of massive hemothorax, you insert the tube drain. And when you insert the tube drain, you will see what comes out and how much comes out. So what is that defined as? Initial tube drain output. So initial tube drain output. Students, initial tube drain output more than 1000 ml in penetrating injuries. So बच्चे, in more than 1000 ml in penetrating injuries, yeah, that's suggestive of a significant injury and it's time to take a call for surgery. Or students, if it is more than 1500 ml anyways, in blunt trauma, it qualifies for what? Massive hemothorax. Suppose initially it came out to be 350. What to do? Follow it. Follow it in the next hour. How much? So 350, now 600. Again 1 hour, 300 came out. Or maybe 250 came out. Next hour it is 850. So if you see persistently, the drain output is increasing at an average of more than 200 ml per hour. So what is that? So tube drain output, that is defined as tube drain output more than 200 ml per hour. So tube drain output more than 200 ml per hour for 3 consecutive hours. For 3 consecutive hours. Fourth is caked hemothorax. Now, what is the concept of caked hemothorax? What is caked hemothorax? Suppose you got a patient of hemothorax, yeah, and you had put a tube. Nothing came out. That was a dry. Again, you put the tube. Nothing came out. There could be a possibility that first you have not placed the drain properly. That is why you attempted a second drain. But if 2 drains doesn't give you anything, control your emotion. It shouldn't be like one hole here, one hole here, one hole here. You have seen that movie Dabang. Chedi Singh, hum tumhe itne ched kar denge. Yeah. So वो वाला phenomenon नहीं होना चाहिए. But if the drains are not able to evacuate the clot, that means blood is no more in the form of liquid. It has been clotted. So what is caked hemothorax? Students, it is defined as a clotted hemothorax. A clotted hemothorax. So caked hemothorax or a clotted hemothorax. Point number 1. Point number 2. The next very important point that we all have to understand is that what is the criteria for clotted hemothorax or a caked hemothorax? Criteria is failed 2 tube thoracostomies. Thoracostomies. Are you getting this? So failed 2 tube thoracostomies. This is what is very important. So let us go to our question. All except are true for the following condition. Yeah. Pulmonary vein is the most common source. Not at all. It is the intercostal vessels. Intercostal vessels. More than 1500 ml requires surgical exploration. True. Caked hemothorax requires, how can you remove cake or clot? Tube thoracostomy is the first line preferred management. Absolutely true. You're getting this? Absolutely true. Next question. A 33-year-old female with this kind of profile. Palpitation भी है, amenorrhea is also there, proptosis is also there. What are you actually suspecting? What are you actually suspecting for this patient? Awesome. Awesome. And probably what? What? Very good. Very good. You're dealing with a what? Classical patient of a Graves. So Graves. Graves. Now, if you see Graves, how can you identify? Proptosis is okay. Yeah, proptosis is okay. Clinically, if you see, can you see the visible upper sclera? The visible upper sclera. What is that known as? Dalrymple sign. Dalrymple sign. Is that? And then we have a very significant what? Stellwax infrequent stare. Yeah. Stellwax infrequent stare. Infrequent stare. Yeah. So let us see how we'll evaluate. Patient presenting with proptosis, palpitation and amenorrhea, they are classical features of hyperthyroidism. But by clinically seeing this patient, you can come to a diagnosis. Let us talk about evaluation of the patient. Yeah. Let us talk about evaluation of the patient. So when we talk about the patient with Graves, what is the concept of Graves disease? But this is also known as diffuse toxic goiter. Yeah. Diffuse toxic goiter. Now, what is the association or the risk? But they may be the most common is their autoimmune. The most common is autoimmune. Yeah. The next is they may be idiopathic. They may be associated with infections. They may be associated with pregnancy. They may be associated with lithium. So lithium. So autoimmune, idiopathic, infection, pregnancy, lithium toxicity. The reason behind this, yeah. Reason behind this. Now, what is the basic concept? Yeah. Very good, Ajay. Very good. Kritika Bachche. Very good. Let us see. What is the concept? So when we are talking about the concept of this, the concept is CTLA4. CTLA4. What is CTLA4, students? I'm not able to recall this. Can anyone help me with this? Cytotoxic, something with cytotoxic T lymphocyte antigen 4. Yeah. What is this cytotoxic T lymphocyte antigen 4 going to do? Then what is this going to do? This is going to what? Stimulate B lymphocytes. And this stimulates B lymphocytes. And what is this B lymphocyte going to do? B lymphocytes. And this is going to generate TSIs. What is TSI? Thyroid stimulating immunoglobulins. And what are these thyroid stimulating immunoglobulins going to do? But they are actually gain of function. Yeah, they are actually going to do a gain of function. And what is this gain of function? What do you mean by this? But it is diffusely going to stimulate the entire gland. Yeah, entire gland. And that is why there is increase in size, and that is known as goiter. Since the action is panthyroidal, we say diffuse, and it is producing unwanted, unnecessary features of hyperthyroidism. That is why diffuse toxic goiter. Do you know this is also TSI? They are also thyroid stimulating hormone receptor antibodies. Yeah, someone has already written them. Someone has written, I think, yeah. So TSH are antibodies, and do you know this is the hallmark? Bache, hallmark presence. So when we talk about diagnosis, a patient with hyperthyroidism, that is increase in free T3, free T4, decrease in TSH, and along with that, in more than 90% of the cases, there is thyroid stimulating antibodies are elevated. Is that clear to you people? Now, when we talk about the presentation, I'm not going to discuss that presentation part. We have lot of features of hyperthyroidism. So, features of hyperthyroidism, yeah. And then we have also some Graves specific features. Now, if you talk about Graves specific features, what are the classical features that are present in eye? In the eye, which is known as Graves ophthalmopathy. But see what happens? There is spasm of the upper eyelid. And because of the spasm of the upper eyelid, lot of things are seen. So spasm of upper eyelid. So because of this, if you ask the patient to follow the moving finger up and down, there will be what? A lid lag. So what is that lid lag? Von Graeff's sign. What is von Graeff's sign? This is upper eyelid lag. Then because of the spasm of the upper eyelid, this is Dalrymple, visible sclera. What else? Because of this, you also have the Stelvach's infrequent stare. And if you ask the patient to look straight and then all of a sudden you will bring a finger in the field of vision, normal patient's eye will converge. Iski nahi hoti. What is that known as? Loss of near accommodation. This is known as, anyone? Mobius sign. But see, there are 10-15 signs. I'm not going to go for that. Let us see. Hyperthyroidism is associated with diarrhea. Hypothyroidism is associated with constipation. That is a feature of hyperthyroidism. This is not Graves specific. Now, what do you see in the skeletal system? Skeletal changes. Yeah. Do you know that first of all, hyperthyroidism is associated with osteopenia, osteopenia. The next thing is there is a Codman's reaction, like subperiosteal reaction, like Codman's triangle. You must have seen the subperiosteal bone reaction. So we say subperiosteal bone formation. Actually, there is no true bone formation, it's a bone reaction. What else? You get to see swollen metacarpals. And what is this swollen metacarpals? What is it representing? Swollen metacarpals. This is what is known as thyroid acropathy. This is what is very important. So these are the skeletal changes that we get to see. Next is we have one more. What is that? What about the skin? You get to see on the skin pre-tibial myxedema. Students, the word myxedema is a misnomer here. Why myxedema is misnomer? Because myxedema is referred for the hypothyroidism case, not for the hyperthyroidism case. Are you getting? This is what is very, 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 very important. Along with that, since the gland is hypervascular, the superior pole vessels might give you that what? Palpable thrill or auscultable bruit. So palpable thrill along the superior pole. This is because of the hypervascular gland. Yeah, this is what is. So palpable thrill or auscultable bruit. Now the last part is how do we manage? Now the management is very, very, very simple. We have anti-thyroid drugs. What is so important about antithyroid drugs? So we have antithyroid drugs, point number 1. Second is we have radioactive iodine 131 ablation. 131 ablation. And the third is we have surgery. Bache, the prime objective of this antithyroid drug, what was that? The prime objective is, the aim is to achieve euthyroid status. So to attain euthyroid status, do you know any surgery? You cannot do any surgery until and unless you have a euthyroid status. कोई भी surgery नहीं कर सकते. To attain euthyroid status, you are utilizing these drugs. So one very important thing is, what are the ways you do this? Yeah, what are the ways? We have methimazole. We have methimazole, and do you know methimazole? We start with neomercazole. Neomercazole is the brand, GlaxoSmithKline, and we start with 10 mg. We can escalate it up to what, 40 mg. Gradually we go for. So methimazole is the most potent. The only thing is, this is contraindicated in first trimester. Why it is contraindicated in first trimester? Because of its what? Because of its teratogenic effects. Yeah, it causes cutis aplasia. Next, what else we have? You have PTU, propyl thiouracil. Yeah, propyl thiouracil. Actually, this is safe in pregnancy. This is safe in pregnancy. Safe. But the drawback is, first of all, you have to take a tedious dosing, so lesser patient compliant. Second is, long-term use of PTU causes a liver problem. So hepatotoxicity in a long-term use. So that is why it is not used. So in first trimester we shift to PTU, else we continue with what? Methimazole. Next is we can use beta blockers. Now what is the advantage of beta blockers? First of all, it blocks the T4 to T3 peripheral deiodinization. So it blocks peripheral deiodinization. So peripheral deiodinization is blocked because of this, and that is why, first of all, the T3 is not formed. When T3 is not formed, the end organ receptors are actually responding to T3, not to T4. So peripheral complications, the organ related complication, the organ specific complications, they are reduced. Point number 1. The second important thing is, not only this is rate and rhythm stabilizer. So you know that many patients have palpitation, they will develop arrhythmia. So rate and rhythm stabilizer. This is what is very, 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 very important. Next is, there are certain cases when you will have to need the intervention in emergency. So bache, if surgery has to be planned in short interval of time, you can use iodine. Yeah, you can use Lugol's iodine. You know, iodine has a dual property. It has a dual property. In case of deficiency, it is stimulatory. Yeah, and in case of excess T4, it is inhibitory. And what is this dual property known as? This is known as Wolff-Chaikoff or Chaikoff effect. So Wolff-Chaikoff effect. Are you getting this? Next is, sir, I want to ask you, one student is saying, sir, I want to ask you, can we use antithyroid drug as a first line therapy? Yeah. Can antithyroid drug be used as first line therapy? Can it be used? Answer is yes. Yes. And when if the gland is small, what do you mean by gland is small? Less than 30 grams. Less than 30 grams or 40 grams. Basically, less than 30 or 40 grams. Second is, no toxicity, no life-threatening features, low TSI levels, and along with that, if there is a rapid response. So if there is a rapid response, if these features are clear, if these features are present, Yes, you can go for. Are you getting this or no? Yeah, this is what. This is what. Very good, Krish. Very good. So next is we have radioactive iodine 131. The definite managements, if you talk about definite. Achha, one more thing. What is the regimen? What type of regimen do we use? Regimen of antithyroid drugs. Achha, either we can go for a high dose antithyroid drugs. So what will happen if there is high dose antithyroid drug? This will lead to sudden hypothyroidism. Sudden hypothyroidism. Yeah. And then what you are going to do? You are going to replace. You are going to replace with what? T4. So replace with T4. What is this known as? What is this known as? This is known as block and replace therapy. Block and replace therapy. Are you getting this? Block and replace therapy. The second is, this is first. But do you know that it is having a lot of complications? So instead of this block and replace, you can do a gradual escalation. Like I was telling you, methimazole 10 start kari, no effect, 10 BD, then 10 escalated 20 OD, 20 BD, like this. Then up to 40, you are increase. So this is what is known as step ladder regimen. Step ladder regimen. So step ladder regimen is very, 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 very important. Very important. So this is a step ladder regimen. Now next is, when we are talking about the final treatment, interventions, we have two standard interventions. What are they? Radioactive iodine 131, and we are going to go for surgery. But always remember, the indications of surgery becomes contraindications for radioactive iodine. Otherwise, you cannot say which is preferred, because it is the choice of your client. Who is paying money? Client. Client is paying, so client will decide. The only thing that you have to guide, that it should not be a contraindication in that case. It's like that. So you decide that your client wants a surgery when the surgery is contraindicated. So you will not do. You will not say that patient wanted and then the complication happened, and then you say you wanted. It's your choice. It's your duty to explain it and everything. So if you talk about radioactive iodine, what are the contraindications? Answer is young females, pregnant, lactating, large glands, that means more than 80-gram glands, a patient with a smoker, and a patient with Graves' ophthalmopathy. Which is why so much injustice with the smokers? Do you know, in smokers post radiation, it has been seen that the incidence of Graves' ophthalmopathy rises drastically. Is that clear or no? So all these contraindications, they will become what? Indications for surgery. They are what? Indications for surgery. See, what surgery do we do? But we only do one surgery, that is total thyroidectomy. I've seen a lot of people teaching there is something which is known as leaving 4 to 7 grams on idle side and this and that, subtotal unilateral, which is known as Hartley-Dunhill, and this and bilateral. All this is a genuine bluff. There is nothing. How can you leave 4 to 7 grams? You'll say I leave of a size of thumb. Your sum is different. Male, female, African, gender based if you see. So you cannot decide or quantify actually what is 4 to 7 grams. Are you getting this? Then someone went to a height of near total thyroidectomy where you are leaving 1 gram of tissue near ipsilateral ligament of Verres or any ligament of Verres, right or left, any side. This is genuine bluff. Either the person has not done this, or he or she is not a surgeon. Is that clear or no? So with this, we finish this concept of Graves' disease. I hope you enjoyed this concept. Let us see what we do next. Yeah, let us see what we do next. Okay. Let us talk about this question. A 32-year-old presents with painful postprandial swelling in the submandibular region. 32-year-old presents with painful postprandial swelling. बच्चे प्लियोमॉर्फिक एडिनोमा J will not be painful, and if you see the location, ये होती है लोकेशन प्लियोमॉर्फिक एडिनोमा की. So here you have parotid, and here you have what? The submandibular gland. So first of all, it will be a pathology of submandibular gland. Sublingual की यहाँ होगी, sublingual gland. Yeah. Are you getting? So this is a submandibular gland swelling, basically. Postprandial swelling. Why it's having a postprandial swelling? Let me tell you. This is a classic hint. What is this? See, बच्चे postprandial. What do we require? Postprandial, there is increased requirement of saliva. Saliva. Or during meals. Yeah, during meals there is requirement of saliva, and the maximum flow, the maximum basal flow is contributed by submandibular gland. So whenever you are eating, imagine this is a scenario like this. Whenever you are eating, this gland will actually swell up in size. Why? Because it is not able to drain its what? Saliva out. That means it may be associated with some obstruction, and that is why postprandial swelling is evident. So actually this is a patient of salivary colic, and salivary colic in this area, this may be associated with what? Associated with stones. Very good, very good, very good. Stones, sialolithiasis, greater than tumors or infections. Infections. Are you getting this or no? So this is, all these things are actually going to cause blockage of the what? Submandibular gland and its duct. So let us talk something about sialolithiasis. So the next topic that we are going to discuss is a sialolithiasis, and this is very, 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 very interesting. Sialolithiasis. Now, when we talk about sialolithiasis, what are the important points that we all should be knowing? Sialolithiasis means the stone in salivary gland. And do you know that most common site for them is the submandibular gland and its Wharton's duct. And what is the name of this duct? Wharton's duct. Are you getting this? Wharton's duct. Now, if you see the concept of sialolithiasis, what are the important things in this sialolithiasis? What are the important things in this sialolithiasis? Why this submandibular gland? Why submandibular gland? Yeah. Let us see the answer. The stone will actually form at a place where there is some level of what? Stasis. Some level of stasis. So do you know the first thing is anti-gravity drainage. So anti-gravity drainage of saliva, point number 1. The second important point is increase calcium concentration, and then third is increase viscosity of the concentration of you can say the secretion. You know, they are not having serous, they are having a viscous secretion. And the last is the speed breaker. Where is the speed breaker? Where is this speed breaker? Hooking of duct by lingual nerve. Hooking of duct by lingual nerve. And because of these reasons, you actually have stasis. So all these things will increase the stasis, and students, stasis will actually increase the risk of what? Yeah, stone formation. Are these points clear to everyone or no? Yeah. let us see one more thing. Let us see one more thing. The next very important thing is, let us see, when we talk about the salivary gland stones, more than 90% of them, are radio opaque. Again, more than 90% of them are located at the submandibular gland. बच्चे parotid duct and parotid gland stones. So parotid gland and its duct stones, they are what in nature? They are radiolucent. Now, what is the investigation of choice? How do you do diagnosis? Let us see. Diagnosis. Investigation of choice is a CCT. Yeah. You can also go for an NCCT, but CCT is what is, because CCT is preferred. Next is. But the first line is actually OPG. What is OPG? Orthopentomogram. Yeah, this is what. The next very important thing. What is the presentation? The classical presentation is salivary colic. Now, what is salivary colic? Salivary colic is defined as acute, painful, tender. Yeah. So acute, painful, tender swelling. So this is acute, painful, tender swelling over submandibular gland region. Yeah, over submandibular gland region with food intake, and why it is known as colic, which decreases or even resolves 2 to 3 hour postprandial. Now, what is this concept of this postprandial resolution? You know, if you draw a pain versus time graph, the intensity of the pain will shoot to the maximum with the food intake, and 2 to 3 hours later, yeah, it will come back to the baseline. Are you getting this? This is what is very important. So this is 2 to 3 hours postprandial. Let us move forward. So this is the concept of salivary colic. One more thing is, let us talk about lingual colic. So when we are talking about lingual colic, this is the pain radiated to tip of tongue. And why it is? Because of the irritation of the nerve by the impacted stone. Let us see what is the management. Let us see. This is very simple. Yeah. Pseudocolicky means, but see, this is what is colicky. There is nothing known as pseudocolicky pain. Colicky pain is defined. There is no standard term like pseudocolicky. Colicky pain is the pain which shoots up and comes back to. A referred pain-like scenario might be taken as a pseudocolicky pain, but actually there is a term colicky which increase and comes back to the baseline. So by the impacted stone, if there is irritation of the nerve, that is what. Next is, let us talk about the treatment. Now this is very simple and easy thing. So the first topic of concern is whenever we are talking about submandibular gland stones. The next thing that we all have to understand is what is the location of stone with respect to lingual nerve. Why? Because lingual nerve is very important for us. Now there could be two answers. Either it is located anterior or it is located posterior. So anterior or posterior. Students, if it is anterior, what is the approach that we follow? What is the approach that we follow if it is anterior? If it is anterior, you will follow oral approach. Oral approach. What is the technique? Achha, if it is posterior, you will follow the cervical, or you can say neck approach. Neck approach. What are you going to do? You are going to go for duct exploration. Duct exploration followed by removal of stone. Removal of stone. What is this? This is a very easy thing. Try to understand the scenario like this. Bache, if this is the place where the duct with the nerve is, and this is the stone, what are you going to do? You are going to explore the duct. This is what you are going to do, a ductotomy. And imagine if this is the stone, what you will do? You will take it out. You will simply take it out of this. Now, what is not done? What is very, very, very important? Important is closure of the duct is not done. Why? If you close, there will be stenosis. These are narrow structures, narrow pipes. So closure is not done. Are you getting? The closure is not done. The next very important thing that we all have to understand is when we talk about the posterior approach. When we talk about the posterior approach, what is so important? What is so important? If the stone is in the posterior part to the nerve, and imagine if you are going via what approach? Oral approach. You will first encounter the nerve and damage it. So oral approach is contraindicated here. Now what are we going to do? So we are going to make incision. We are going to make incision below the mandible, 2 finger breadth below the mandible. Yeah. Just over the duct, you will palpate. Ajay, you will palpate the duct, and then you will open up the duct over that. Are you getting this or no? Okay. Now here, 2 finger space, 2 centimeter below what? Mandible. So 2 finger space below mandible, and this is parallel to the mandible. Parallel to mandible, we make the incision. Yeah. Parallel to mandible, we make incision. And this is actually deepened right up to the subplatysmal level. Now, 2-3 questions here I'll discuss. Try to understand what are you going to do. So imagine you have gone down. And this is how the gland is. Yeah. This is where the nerve is. Yeah. So what is the first task that you have? You will ligate the duct as high as possible under the vision, and you will excise the gland and the stone along with it. So are you getting this or no? Now, why you ligate the duct? Why you ligate? So ligation of duct. Why you are going for ligation of duct? Can anyone tell me? Yeah. Answer is to prevent fistula formation. To prevent fistula. Is that clear or no? Here you don't need to think about, because there you are opening up the internal, you can say the opening will be in the internal part of the, you can say, oral cavity. Here it will cause a fistula. Next is, why you are so much concerned about the submandibular gland? The answer is submandibular gland is associated with what injuries? So what are the nerve injuries? What are the nerve injuries associated with submandibular gland? What are the nerve injuries? Can I have it from the audience? What are the nerve injuries from? So the most common is lingual. Then the most common during incision. Students, come on, tell me, during incision. Hypoglossal. Where else you have to remember this hypoglossal nerve injury? Have you heard of Lyre sign of chemodectoma? Have you heard of that chemodectoma, Lyre sign, paraganglioma at the carotid bifurcation? Yeah. Have you heard? There also. So most common nerve injury, during chemodectoma surgery, during chemodectoma removal, or you can say carotid body tumor, during carotid body tumor removal, answer is the same. What is the answer? The answer is hypoglossal. So hypoglossal nerve. hypoglossal nerve. Are you getting this? We also might have injury to the other structures, but hypoglossal सबसे common होती है. What else? Nerve to mylohyoid nerve. What else? What else? It is the marginal mandibular branch of facial nerve. So marginal mandibular branch of facial nerve. So marginal mandibular nerve. So these are some important things that we should be knowing. Now, what could be the other causes of, you can say, what could be the other causes of you can say, of salivary colic? So the other causes of salivary colic, it could be tumors. Yeah, it could be tumors. So when we talk about tumors, it could be inflammations or inflammations. But just tell me, what is a Kuttner's tumor? Tell me, what is Kuttner's tumor? Can anyone tell me what is a Kuttner's tumor? The word Kuttner's tumor, the word tumor is a misnomer. What is that? It is defined as chronic sclerosing CL-adenitis of submandibular gland. This is what is Kuttner's tumor. Yeah. When you talk about the tumors of submandibular gland, but 50% of them are benign. And if you talk about 50% benign tumors, the most common benign is pleomorphic adenoma. And 50% of them are malignant. But what is the most common malignancy? Can anyone tell me most common malignancy? Answer is adenoid cystic. Vardhan's tumor is exclusive to parotid. So you're getting, Vardhan's is exclusive to parotid. So adenoid cystic tumor or adenoid cystic cancer. Do you know 2-3 important points about adenoid cystic cancer? This is also known as anyone? This is also known as cylindromatous tumor. So cylindromatous tumor. One more very important thing is adenoid cystic. This is the most common malignancy. Of submandibular gland, sublingual gland, and also minor salivary glands. What also is important for them? There's one more point which is important. What is that? They are associated with two very important points which make it aggressive. They are associated with perineural invasion and hematogenous spread. So they are known as very aggressive tumor because of their nerve invasion and hematogenous spread. One very unique property about them. What is unique about them? The unique is, since they are having hematogenous spread, therefore increase risk of METs. But the unique property of this tumor is that even whenever we have metastasis, it is considered as an absolute it's considered as absolute contraindication for resection. Very good, Ajay, very good. I'll tell that also. But important point is metastasis, METs in adenoid cystic. METs in adenoid cystic are dormant for a long time, and therefore not contraindication for resection. Are you getting this? So they are not a contraindication for resection. Are you getting this? On HPE, on histopathological examination, on HPE, you get to see a Swiss cheese appearance. a Swiss cheese appearance. On HPE, you get to see a Swiss cheese appearance. Swiss cheese appearance. Are you getting this or no? Or snowstorm appearance. Snowstorm appearance. What else is again very important? What else is important? Important is the apart from this cylindromatous tumor, or you can say adenoid cystic tumor, where else do you get the Swiss cheese appearance? In salivary glands. Can you tell me? Let's say recurrent childhood parotitis. Point number 1. So recurrent childhood parotitis, the Swiss cheese appearance is present. Where else it is present? Where else? Have you heard of HIV parotitis? So even in HIV parotitis, this is present. Important. What is the management? Radical resection, and along with that, students, radiotherapy is must. Why radiotherapy is must? Because of the property of perineural invasion. If you don't do radiotherapy, the recurrence is inevitable in this case. So is this concept of the salivary gland question clear to you? So diagnosis be clear, approach be clear, management is also clear. Done. Identify the procedure and the instrument. Tell me, identify the procedure and the instrument. Tell me this. Tell me something. Let us see. The answer is, isn't it looking like that electronic trimmer like machine? First of all, you are taking some skin out. So of course it is used for grafting. It is not a Humbee's knife. Humbee's knife is like barber's ustara. Have you seen that ustara? This is an electronic dermatome. This is electronic dermatome. Are you getting this? Electronic dermatome. So this is not a Humbee's knife. This is electronic dermatome. They are very important points. Just a minute. Okay. So let us discuss few important points. Let us discuss few important points on this. So what is, I want to ask you, what is the graft contractions? What are the graft contractions? Can anyone tell me what is the concept of graft contractions? So whenever we talk about graft harvest, can you tell me the contraction? Okay, so when we talk about graft and when we talk about graft harvest, harvesting of graft is a special technique, and this is done by either Humbee's knife, or this is done by what? Electronic dermatome. David, this is electronic dermatome. The instrument that you are seeing, this is electronic dermatome. This is not a Humbee's knife. I'll again come back to this electronic dermatome. Now, one very important thing that we all have to understand is, if you see, the moment you take out the skin, the skin becomes crumpled. And this is very important. So this is important. So what is graft contraction? What is the concept of graft contractions? There are two types of graft contractions. What are the types of graft contractions? We have the primary graft contraction. and we have a secondary graft contraction. So primary versus secondary. Now what is primary graft contraction? This is the graft contraction. This is the graft contraction after harvest and before grafting. Before grafting. Is that clear or no? So why this happens? Because if you see the skin is under the elastic strain, and whenever you release it, it will be what? Contracting. So before grafting and after harvest. When you talk about secondary contractions, this is the graft contraction. This is the graft contraction noted after harvest, after the grafting. Now, which is undesirable? Tell me, which is undesirable? Both are undesirable. But which is mostly, you can say, not wanted by anyone? This is the secondary. A graft with a high secondary contraction is never desired. Why? Because just after the process of grafting, it will strain. So try to understand, if you take out a graft, suppose you take out a graft from this side. Yeah. Let us take out a graft from this side. So you have taken out a graft. Let me take out a graft from this place. And after you take out the graft, there will be some shrinkage. There will be some shrinkage. This is what is known as what? The primary contraction. This is what is primary contraction. And once you have grafted the tissue, suppose you have grafted this, and then after grafting, it contracts in size. This is what is known as, suppose after grafting it contracts in size. This is what is known as secondary contraction. Yeah. This is what is secondary contraction. Next is, that means there is nothing known as 100% uptake or covering of the graft. 100%. So what is defined as a take of graft? What is defined as take of graft? It is percentage acceptance of graft by recipient bed. So percentage acceptance of graft by recipient bed. This is known as take of the graft. Try to understand. This is what is the skin, and this is what you have grafted. After 1 week, when you open, you see that it has decreased in what size? So it has decreased in size, and this much part is covered. So suppose if 75% of the wound has been covered, you will say that take is equal to what? In this case, 75%. Yeah. Now, what are the steps of graft acceptance? This is also very, 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 very important and commonly asked. What are the steps of graft acceptance? So when we talk about graft acceptance, what are the important things? The first is stage of imbibition. Stage of imbibition. Then this stage lasts for 24 to 48 hours. 24 to 48. To 48 hours. So within 24 to 48 hours, this is going to get what? A bit accepted. What is this stage of imbibition? This is deposition of fibrin and plasma molecules. So deposition of fibrin plus plasma molecules. And what do you get by the stage of imbibition? What do you get? What is the role of the stage of imbibition? The role is it provides moisture to the it provides moisture. You know what is a graft? You take a piece of tissue and you place it at another place. So what will happen? It will keep on getting what? Ischemic. So the ischemic graft get nutrition, gets moisture by different ways. So stage of imbibition, it provides moisture. Then the second is, after this, We have second stage, and this is known as stage of inosculation. So stage of inosculation. So stage of imbibation and stage of inosculation. When we talk about stage of inosculation, it lasts for 48 hours. For 48 hours. The important thing is, what is stage of inosculation? It is development of fine vasculature. So development of fine vasculature in between the recipient bed and the graft. What is the role? What is the function? The role is to provide moisture to the graft, and along with moisture, nutrition to the graft. Very good, very good. And bache, the last stage we have is stage of revascularization. So stage of revascularization. The stage of revascularization. When we talk about stage of revascularization, what is so important? Answer is, it also will last 48 hours. Yeah. What is the concept of the stage of revascularization? Development of well-defined vasculature. So development of well-defined vasculature. Always remember, thus the grafting will take how much time? There are a lot of questions which are asked on this also. Therefore, graft acceptance requires at least 5 to 6 days. I'm going to ask you, what is the reason for graft rejection? Yeah? What is the reason for graft rejection? Can anyone tell me what is the reason for graft rejection? Anyone? Graft rejection. The concept of graft rejection is the hematoma developing under the graft. So the hematoma under the graft is the most common cause. It's the most common cause. Just a minute, student. Okay. So hematoma under the graft is the most common cause, greater than what? Sepsis. Greater than sepsis. The next is, what are the types of graft? Can anyone tell me quickly? What are the types of grafts we have? Yeah. The grafts are of 3 types, basically. Yeah. The grafts are of 3 types. We have split thickness skin graft. We have split thickness skin graft. Okay. We have full thickness skin graft, and we have the composite graft. So we have composite graft, we have split thickness skin graft. Bache, split thickness, they are most commonly used, and here actually variable thickness of the skin is used. Variable thickness of the skin is used. Now when we talk about various thickness used, this is very important. The split thickness skin graft, they are further of 3 types. STSGs. If you talk about the types, what are the types? We have a thin variety. Thin STSG. This is also known as Thier's. Very good, Matthews. Thier's Ollier graft. Do you know the split thickness skin graft? They have low primary contraction, but they have high secondary contraction. Now you will be saying, sir, 5 minutes before you were saying any graft with a high secondary contraction is undesirable. Why do we use it? Since we are leaving at least the reticular dermis, there is no scarring. So if I have taken a graft from this side, Let it be rejected. I will take it from another side. After few weeks, this side is also ready. We can take a regraft from this. So no issues. Continuous availability makes it what popular. Very good, Ajay. Very good. So if you talk about thickness, the thickness we have 0.006 to 0.012 inches. Then we have intermediate thickness, intermediate STSG. This is what is known as Paget's graft. This is what is known as Paget's graft. 0.012 to 0.018 inches. And then third is full thickness. Full thickness. I'm saying full thickness. It is thick STSGs. Thick SDSGs. What is thick SDSGs? Better known as thick SDSG. 0.018 to 0.024 inches. क्या बोलते हैं इनको? क्या? Anyone? Oh, I've just sorry. The intermediate is known as Blair-Brown graft. I'm sorry. The Blair-Brown graft, and this is what is known as Paget's graft. This is known as Paget's graft. But when we talk about full thickness, FTSGs, they are known as what? Wolf cross graft. Wolf cross graft. So Wolf cross graft, the advantage that they have is they have low secondary contraction. Yeah. सर मैं 9th में हूँ, बहुत बढ़िया बात है बेटा, बहुत बढ़िया बात है. 9th में बहुत अच्छी बात है. 10th में भी जाओगी, 11th में भी जाओगी, बहुत बढ़िया, बहुत बढ़िया. So Wolf cross graft. So STSGs are one and FTSG is another. When you talk about FTSG, what is that? They have low secondary contraction and therefore they are the best. But the drawback is that they have, since you take out the full thickness, they are associated with what? Scarring. Yeah, scarring. सर में CT स्कैन, DCCT क्या बच्चे, क्या बात होगी? आदित्य बच्चे क्या हो गया? 9th में हो, अच्छी बात है, बहुत बड़ी बात है. मतलब 9 बार 10 बार लिख दोगे कि 9th में हो, कोई नहीं. छोटा बच्चा खेलेगा अपना, ये बच्चा खेलो आराम से खेलो. Like my daughter also loves to play ना, she gets a keyboard and then she is typing. So नहीं, बच्चा ही अपना, कोई दिक्कत नहीं, आराम से. So composite graft. When we talk about composite graft, what is composite graft, students? Along with the skin, you are using adnexa. You are using adnexal structures. What about the adnexal structures? What adnexal structures? Like recently, you must have seen my video. I have shown in the classes also. I have done a auricular graft. So what we do, if you have to do a tip of nose reconstruction, you need that columella effect. So you inside this is the auricular graft. This is a posterior auricular graft. You will take up and you will place it here. What is that? So I've shown that video in the class and many times on the special class also. So अब वो videos कुछ तो special में फर्क, कुछ तो plus में फर्क हो गई. So in the plus classes I have already shown all these, how we do everything, how we do a graft harvesting, etc. So composite graft, example is tip of nose reconstruction. Tip of nose reconstruction. So tip of nose reconstruction by posterior auricular graft. Posterior auricular graft. Can anyone tell me what is the concept of meshed graft? कोई बता सकता है मेरे को? What is the concept of meshed graft? Yeah. Can anyone tell me the concept of meshed graft? बताओगे? नहीं बताओ, कोई बात नहीं, मत बताओ. I'll tell you. बच्चे, meshing of graft, actually this is done for the what? Generally for the split thickness skin graft. This is meshing of graft. So what is the concept of meshing of graft? So meshing of graft to increase two things. The surface area. To increase the surface area, point number 1. So meshing of graft done to increase the surface area, and second, to increase the acceptance. how do you increase the acceptance? Look, what is the reason behind graft rejection? The reason behind graft rejection is, if this is the graft, suppose this is the recipient bed and this is the graft. In between them, what used to accommodate? The hematoma. The hematoma used to accommodate. And that is why the graft got necrosed and rejected. Yeah. So what will happen? What will happen if I make a graft and then there are meshes inside that graft? So what is this meshing of graft? I'll make holes. The advantage of making holes is that any collection, even if it accommodates, yeah, will be egressed out. So there will be egress of collections. Yeah. So there is increased acceptance. The second is, when you do holes in the graft, you make the graft weak, and hence you can increase the area. Can you see? You can stretch it. But there's a limit. You cannot be greedy. You cannot say, I'll take a handkerchief type of graft and make a sari and wear it and dance. बच्चे तो वही बात होगी, हम तुम्हें इतने छेद कर देंगे छेदी से, you know. So बच्चे, there is a fixed ratio of increase. So increase, the maximum increase can be 1:1.5 or 1.6 times. The maximum increase is 1:1.5 or 1.6 times, and this is very, 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 very important. Are you getting this or no? Beyond this, the graft descends. So now everyone will be happy, sir. Every graft that we'll be doing this. The drawback is, what is the drawback? There is increased pigmentation. So the increased pigmentation is a big drawback of this. Increased pigmentation. So with this, I finish off this session. I hope you enjoyed this. Yeah, I hope you enjoyed. And I'll be back with many more such interesting sessions. Do follow me on Unacademy. Do press the icon of Unacademy and follow me. And use the code surgery live, or you can use the code Dr. Dixit to join the class. Do share the links with your friends, and do keep committed to Unacademy, and do enjoy the resources that we have brought it for you. So till then, bye.